Well, good morning, everyone, and welcome to our grand rounds at the Houston Methodist DeBakey Heart and Vascular Center. We have a very special grand rounds today, but before we start, I'd like to remind you a few things. One is that our conference, as usual, is videotaped and streamed live, and actually you could see it on the DICET channel, or DeBakey Institute Education, on the YouTube channel next week. So I think it would be great. And also there's usually an interview with our grand round speaker. And also when you speak, please use the microphones and please also complete the surveys for our CME accreditation. What a pleasure today to welcome Dr. Martha Gulati, who's giving the grand rounds on a very special topic that we haven't covered for some time, I would say, and I think is very important. Dr. Gulati is professor of medicine and chief of cardiology at the University of Arizona in Phoenix. Before that, she was at Ohio State University, where she was the Sarah Ross Sauter Chair in Women Cardiovascular Health, and was the lead person for developing the Women and Heart Disease and Prevention program at Ohio State University. One thing that differentiates Dr. Gulati is her passion for prevention and women and heart disease. So if you look at whatever she has touched, whatever she has done since graduating from University of Chicago, she has been really amazing. She is world-renowned for this. You can see her on every channel, YouTube, Twitter, Facebook, you name it. And she has won so many accolades for her involvement and her drive towards prevention and addressing issues about women and heart disease. She is the author of the bestseller Saving Women's Heart. She is the editor-in-chief of CardioSmart, which is dear to my heart also, since we see that vision. And when I was president of the college, we emphasized the importance of having this patient education and empowerment initiative on the web. She was voted to be in the top 40, under 40, which is quite an honor. From the ACC point of view, she received the first CREDO, which is Coalition to Reduce Racial and Ethnic Disparities in Cardiovascular Outcome. And also she received the National Red Dress Award. She's a co-investigator in the WISE trial evaluation as well as Women Health Initiative. Martha, it is a pleasure to have you here in Houston and address the issue of women and heart disease and give us your perspective on that. Pleasure to welcome you on board.
Well, thank you for having me here today. And I am going to try to make a case about why we need specialized care of women's hearts and vessels. So, and again, thank you for the warm welcome and for all the things I got to see here at this hospital in the last day. Even the ancient Greeks, though, understood there was a difference between women and men. You know, they assigned a goddess of women's health, which is Hygiena. And you know the symbol of medicine, which is the staff with the snake. Hygiena brought the snake. So women are always associated with the snake somehow. But there is lots of differences between men and women. I don't think we really have to convince you, but sometimes it's how we see ourselves. I have a weird sense of humor, but sometimes it's also how we communicate. When men say hi, they just mean hi. When women say hi, we mean a whole lot more than hi. But I think George Carlin probably said it best. He said, here's all you have to know about men and women. Women are crazy and men are stupid, and the main reason women are crazy is that men are stupid. And I'm just quoting a man, so don't get mad at me. But let's talk about the differences between really their hearts. So we've known since 1984, that more women have been dying from heart disease than men. And we've seen these, everyone's seen this graph. But what was really surprising is when we were seeing reductions in mortality in men, we had made great strides. There had been great medications, great interventions that we could do. And we were seeing them being applied to the male population, but not so equally to the female population. And that really started the rise of asking the question, why are women not even included in studies? And that really did spike people's interest to study women and heart disease, but also for the American Heart Association and the American College of Cardiology to actually put out guidelines that really focused on women, because if we weren't applying the guidelines to women, perhaps when they were female specific, people would know what data we knew about women and what we didn't know about women. But you can see that in 2001, we suddenly started seeing reductions in deaths due to cardiovascular disease in women. And that really started in 2001. And of course, there was a very important study that got released in 2001. And that was the results of the Women's Health Initiative. And overnight, as all of you know, the #1 prescription in the United States was hormone replacement therapy, and overnight that changed dramatically. Also in 2001 was the beginning of the Go Red campaign, and shortly thereafter, the guidelines, certain female-specific guidelines started being released. And the good news is, in the last 2 years of the data collection, 2013 and 2014, we actually saw less women dying from cardiovascular disease. Interesting to me, at least, was the fact that that didn't actually make any press, that there was less women dying from cardiovascular disease. The concerning thing is, though, in 2014's data, is that the numbers went up. So compared to 2000, you can barely see it. It's just slight, but what we're wondering is that a trend that we're going to see both for men and women. Is there something about the younger generation that is happening where they are, we have all predicted and said it's possible that the younger generation might not outlive the older generation. Is this the beginning of that trend? So we have to continue to follow. But of the 1.2 million deaths in the United States, just under 400,000 of them are due to cardiovascular disease in women. So, that translates into one death of a woman every 79 seconds. And the second leading cause of death in women is chronic lung disease, accounting for 77,000 deaths, and lung cancer, about 70,000. And breast cancer actually accounts for 41,000 deaths. So most women, most of our patients all, know to get breast cancer screening done. They think that's their #1 health concern. And we know just under 50% of the population, based on our last survey, still thinks that is their #1 health concern, and that they're at more risk of dying from breast cancer. When you put it in these numbers, at least this is a way for us to translate it to our patients. And another way is just in terms of prevalence. How many people live with heart disease? Well, 47.8 million women live with some form of cardiovascular disease, compared to 2.9 million women living with breast cancer. So this is, again, just a way for us to translate it to our patients, because there really is a misperception, or at least a lack of awareness, that getting screening for heart disease should be the #1 health concern of anything. So the other concern that we have is that, when we're seeing reductions in mortality, of course we're happy, but the group that we're not seeing the same reductions in is the youngest women. So we're seeing pretty dramatic reductions in those over the age of 55, as you can see in both of these groups. They're still seeing, but those under the age of 55 are really pretty much flatlining now, where we're not making as much improvement specifically in women. So that's probably the group, they have the most to lose. We really do need to be thinking about, why are younger women dying and not getting the same benefits? And part of the reason, and I'm going to go through my rationale why I think there's different sex differences, but one of the big reasons is, when we talk about women's health, is we really view it with a bikini-like approach. And that term really came from Dr. Nanette Wanger from Emory University. She said we essentially look at the breasts and the reproductive system and almost ignore the rest of a woman when we talk about women's health. And my question, and I wrote an editorial just a few months ago in Circulation, was really, how do we move beyond the bikini? Because she said that in the late 80s, and we're still dealing with this now. When you hear about a women's health center, quite honestly, rarely do they involve cardiovascular disease within that. There's a few exceptions to that, but most women's health programs really concentrate on things that are covered up by the bikini. And we should remind them that the heart also is covered up in the same lines. And this is, of course, a cartoon that's to make you laugh, but it's kind of not, it's very true for cardiology. We have studies of fruit flies, mice, hamsters, frogs, monkey, and men with this condition, but medical research, including using women as subjects, just never really occurred to anybody. And that's really what had happened in cardiovascular disease until really recently. When you look at trials that have been done, whether you look specifically at coronary artery disease or heart failure or diabetes, hypertension, and high cholesterol, you can see that the best we were achieving was close to 40%, but the majority of studies included anywhere from 20 to 30% women in most of the trials, if they included women. And you can see from NIH-specific trials, you can see really it averages around 25% inclusion of women. In most, there is some exceptions. There's been some excellent hypertension trials that achieved higher rates of women enrollment. And we are lucky, actually, the most recent studies related to PCSK9 inhibitors did achieve 50% women. But in all truth, we still see that not enough women are included in trials. And it's probably the first thing I look at any trial I'm reading. I go to table 1 to see just how many women are in this. Because to me, does it apply to my female patients anyway? And really, with prevention specifically, primary prevention trials, women were highly underrepresented in most of those trials. And we know that risk factors in females and men, to be honest, have worsened in the past decade. So it is important that we really do include women. And we know even from the Virgo trial, which was a study of younger women having heart attacks under the age of 55, when they asked them, compared to the men in the Virgo trial, if they were aware of being at risk for heart disease, the awareness was much lower in women compared to men. They didn't realize that they were at risk for heart disease. Even when we look at the FDA, in terms of devices that go up for approval, we know from 2000 to 2007, there was 123 studies that were put up for high-risk cardiovascular devices. And 28% of them didn't even report sex when they put in their submission. And of those that did, 67% of them were men. And there was actually, when they looked over time trends, there was actually no increase in the enrollment of women when they were in terms of the devices. And really the explanation that they gave about why they had an underrepresentation of women, if they put any remark, it was that this represented the quote-unquote imbalance in the sex distribution of the disease in question. And this was for cardiovascular disease. So I'm not sure what imbalance they're thinking, but again, cardiovascular disease is a disease of both men and women. So it is really important for us to look at that as new devices come out. We want to know if they work effectively in women. And we spend a lot of time writing letters to the FDA asking every time that there be fair representation and that women be included. And certainly we did have a champion until recently in the FDA office that was very cognizant of this. But so one question I would ask about in terms of why women do less well than men is really, do we even follow the guidelines equally in women compared to men? So, we know from, this is European data and a little bit older data, but this was just under 4,000 patients, 42% of them were women, and they all had to be diagnosed with stable angina by a cardiologist. And compared with men, they found that women were less likely to undergo exercise stress testing. In Europe, they use a lot more exercise EKG before imaging, and they were less likely to undergo coronary angiography. Despite the fact that women actually had a higher angina class, both initially in 1 year, they were less likely to get statin therapy, less likely to get antiplatelet therapy, and they were also less likely to be offered coronary revascularization. And as a result, women were twice as likely to die or have a non-fatal myocardial infarction, even after, though, adjusting for age, diabetes, left ventricular function, CAD severity, pharmacotherapy, and revascularization. It was also interesting to note in this population, as they were followed followed up, women actually were more symptomatic than men. So you would have thought that they would have got more of these things, specifically perhaps revascularization or coronary angiography. So that was Europe, though, and you may say, well, maybe that's Europe. But we have data from the US too, confirming the same thing. And this is the Get With the Guideline data. And they looked at the odds of a woman getting therapy compared with men. And so obviously, if a woman and man were both equally likely to get the therapy, the odds ratio should be 1. If the odds ratio is greater than 1, it means a woman was more likely to get the therapy. And if it was less than 1, they were less likely. And you see that really there's no ones up there. Everything's less than 1. Women are less likely to get aspirin or beta blocker within 24 hours. They're less likely to be offered any type of revascularization procedure. They're less likely to meet our standard door-to-needle or door-to-balloon times that we put as measures of care. And any type of reperfusion therapy, again, less offered to a woman. The only thing women did better than men was die. And specifically, the ST elevation myocardial infarction group, the women were more likely to die compared with their male counterparts. And we've looked at this repeatedly in the Get With the Guideline data, and this was specifically looking at younger women compared to older women, and they did the divide at under the age of 45. And although the confidence interval is wider because there was less women under the age of 45, really what they found was they said, yes, younger women did worse, but really women of any age were less likely to receive an ACE inhibitor or an ARB after a STEMI. They were less likely to get lipid-lowering therapy. And even upon discharge, their blood pressure was less likely to be well controlled. And again, women of any age were less likely to achieve our door-to-balloon time being under 90 minutes or thrombolytic time. And then, of course, I'm Canadian, so I always look for the Canadian data, wondering if they did better. But they also showed the exact same thing, that they were less likely to be discharged after an acute coronary syndrome with the guideline recommended therapies, particularly beta blocker, lipid lowering, or ACE inhibitors. They were less likely to be offered any type of procedure. And they again were more likely to die both immediately in the hospital and out to 1 year. So these are things that we keep repeatedly looking at, and we see improvements, but we still see the same differences. Even Virgo, which is a study looking at just younger people under the age of 55, and even though they didn't have a mortality difference, they did show that the door-to-balloon time was 8 minutes longer in women compared to men. And if they were transferred from another hospital, they were definitely at higher. There was a 30-minute difference in women compared to men. So even though it didn't translate into a mortality difference, it still is of concern because, again, the faster we treat, the better we think things will be. And we know this also from the nationwide inpatient sample. Although things have improved in terms of reperfusion happening in both men and women, it's offered less often to women compared to men. In-hospital length of stay obviously is reducing for everyone, but again, women tend to stay in the hospital longer than men. And mortality is, again, higher in women compared to men. So these are trends that we continue to watch. And this was just recently in circulation from the Triumph study. They showed that there was actually a sex difference, again, in terms of rehospitalization after myocardial infarction in the youngest women, the women under the age of 55, which are shown in the gray line up here, solid line, compared to the black solid line of men under the age of 55, that there was actually a much statistically significant greater rehospitalization after myocardial infarction in women compared with men. And these are obviously measures that we are all concerned about because we're trying to reduce our rehospitalization rates and are having to be accountable on these measures. So the other thing is, the other question I would throw out is, do women experience cardiovascular disease like men? And a lot of us know this term Yentl syndrome from the movie, or actually it was originally a book called Yentl. And Yentl was a woman who wanted to study the Talmud, and in order to do that, she had to disguise herself as a man in order to be taken seriously. And Dr. Bernadine Healy, who is the head of the NIH, she said, do women actually have to present just like men in order to be taken seriously? And she was actually, when she was the head of the NIH, she was the person who pushed that women be included in trials and that funding be given. And actually the Women's Health Initiative, she fought for that funding. She went to Capitol Hill and asked for that funding to make that study actually happen. So, I mean, her real question is do we have to look the same? And does our disease have to be the same in order for us to treat it? Because that's essentially how women were being treated, was an assumption that they are just like men, because really at that time, women were not included in those trials. And certainly we know that there's differences, and I'm going to go through some of them, but the idea that, the typical angina definition, when we say somebody's having typical angina versus atypical angina, the definition was based on men. It was a very exertional type of symptom that we've given scoring to. And we do know that about a third of women will have more quote-unquote atypical symptoms, if you will. And so that's one thing that we do know. Some women are not going to present in the traditional way. The other issue is that women often have less obstructive coronary disease regardless of their symptoms, whether they have typical or atypical symptoms. We also know, and we've seen this in a number of studies, that women have more angina, regardless of whether they have obstructive coronary disease or not. And yet that still translates into them getting less aggressive medical therapy. And the other issue for these women, especially the ones with non-obstructive coronary disease, is that they do get rehospitalized again and again. They undergo procedures again and again. Often coronary angiography tends to be the one that they get. And this is consuming healthcare resources, because there is, from the WISE study, we know that we spend about $750,000 on women who have non-obstructive coronary disease in their lifetime, compared to about $1 million of what we will spend on somebody with 1 or 2 or 3 vessel disease. So it isn't insignificant when someone has signs and symptoms of ischemia, yet has non-obstructive coronary disease. The other thing is that perhaps we're even underdiagnosing myocardial infarction in women, because when we look for sex differences, it's interesting that we find them. When you think about the troponin values that we use traditionally in the hospital, they were, again, based on men. And they were really, that's what we are using currently. But a lot of the data that's come out of the STIAC group in the UK, they have really shown that, if you take the 99th percentile for women and the 99th percentile for men of troponin values, they are different. And on all their trials, and there's been multiple trials that they've reported this, is that it didn't actually change if they used they're calling it the high sensitivity troponin. If they used the 99th percentile for men, it actually didn't change their diagnosis. But what it did was it changed the diagnosis for women, that we were actually missing women who had heart attacks. So it improved the sensitivity for women by using this measure. And it was also better able to early discriminate those who were not having a heart attack, that we weren't losing people or discharging people who, had heart disease. So in the UK, they're actually using this. And here, they have approved it as of January 23rd, but they said that we couldn't call it high sensitivity troponin. It's called the next generation troponin. And again, I don't know if it has rolled out. It hasn't rolled out in my hospital, but I assume in Europe they're using this like crazy, and we are probably going to be a little bit slower at catching up. But this, I think, is very promising, because who said a woman's heart is the same size as a man's anyway? So it does actually make sense that troponin values might have a different meaning, and we need to actually be critical of older literature. It's interesting that, I don't know if I really thought about this till I started seeing these papers. So The other thing is that the guidelines that we have currently, my other question I'd like to throw out is, do they actually apply in women? And specifically, I'm talking about the stable ischemic heart disease guidelines. And not, I know it must be very hard to see what I have up there. It's just a snapshot of the flow diagram that's in the 2012 stable ischemic heart disease guidelines. And my only point is that all of that flow was really trying to determine who was best to take to the cath lab and look for obstructive coronary disease. And I would just say that there's this overt focus on obstructive coronary disease as the pathophysiology for stable ischemic heart disease. And I'm not sure if that actually applies to women. And I really think these guidelines need to be updated. When you look at the ESC guidelines, they certainly have updated them to say, that to at least state that there's differences in women and that they may not have obstructive coronary disease. We haven't gotten to that point yet. And in fact, most of us probably learned from this diagram. I mean, this diagram is a well-known diagram, but it basically suggested to us that the only point that you could have an abnormal stress test is at the point where you have an obstructive lesion. And we know that's just not true. So, we know that you can have an abnormal stress test with signs of ischemia, even without an obstructive lesion. And so again, I think this needs to get out of our teaching. I mean, certainly this is part of the pathway, but it isn't the only pathway. And we know this from many different studies, and I don't obviously have time to go through all of them, but if you look at the Gusto trials, which were both looking at STEMI, non-STEMI, and unstable angina, you can see that women compared to men, but men also there were people who met these criteria and yet did not have an obstructive lesion. They had clean coronary arteries. And for the unstable angina, it was about a third of women who did not have an obstructive lesion. And that was the first clue that it might have importance, because when they followed these people on, they still had a higher mortality rate than the general population. They didn't have as high as those who had obstructive disease, but certainly it wasn't benign. So I think that there is a paradigm shift that stable ischemic heart disease, this whole idea of it needing to be an obstructive lesion, that was really based on decades and decades of pathological studies that really established that obstructive lesions were associated with ischemic heart disease, but it wasn't that they were looking for other things either. And really, when you look at trials and registries, when the criteria to get in was an obstructive lesion, that does bias what information is out there. And in the past, we would often label when somebody had normal coronary arteries, despite symptoms and a stress test that was abnormal, we'd label that as a false positive. And I would ask you to pause and question of whether those were truly false positives, or if it was a different pathophysiology of ischemia. And like I said, for the women specifically that we've studied in WISE, we've seen that they consume healthcare resources. They continue to have symptoms despite the fact that they may not have a flow-limiting lesion. We know from the ACC NCDR cath PCI registry that whether they come for cath for stable ischemic heart disease or acute coronary syndrome, when you look at women compared to men, women are less likely to have an obstructive lesion, and by this registry, we define that as having a 70% or greater stenosis. But you can see across all races, women are less likely to have an obstructive lesion. And for acute coronary syndrome, certainly you're more likely to find an obstructive lesion. But still, again, the sex differences persist. What's also interesting from the ACC registry was that they found that women, though, actually had a higher mortality rate in both of those groups, regardless of race, compared to men, despite having less obstructive lesions. So it's certainly something that we need to be aware of, because our registries are saying the same thing that our studies also showed. We looked specifically at the WISE study, which is the Women Ischemic Syndrome Evaluation Study, and compared my normal cohort of women called the Women Take Heart Women, which is just under 6,000 women. And we compared them, we matched them on age and race. And what we did is we assumed that the normal cohort doesn't have coronary disease, but the other two groups, which I've labeled here as group 2, is the ones with clean coronary arteries, but had signs and symptoms of ischemia. They all underwent cardiac cath in the WISE study. The third, group 3, which is the black bars, they were the ones who had anywhere from 1 to 49% stenosis in the WISE study, and also, again, had signs and symptoms of ischemia. So when you look at them across risk factors, certainly the more risk factors you had, the more likely you were to go on and have a cardiovascular event. But I think the most interesting group is the middle group, or group 2, the ones who had quote unquote clean coronary arteries, but signs and symptoms of ischemia, did go on to have more adverse cardiovascular events. And that really was our first sign that, we cannot think of this as a benign issue when we know that we knew that we had detected ischemia on a stress test. So it's not that we actually know entirely how to treat these women. Right now, our recommendation is to treat them like ischemic heart disease until we have studies that show is there some unique treatment for women. But we certainly shouldn't just ignore them or tell them that their coronaries are normal and that they don't have heart disease, or dismiss their symptoms. So, when we talk about having, that we know what to do with this type of lesion, all of us as cardiologists get excited by this because we know what to do with it. And maybe that's something that's more of a male pattern or more common in men. But we can't forget that with a cath, we're only seeing the largest of vessels. We're not seeing the small microvasculature. And we have more and more data using cardiac MRI. We're able to see subendocardial ischemia in these women. And so we're very interested. This is what a lot of the work we were doing, was trying to detect this and trying to improve the amount of ischemia that we were able to quantitate using cardiac MRI. And we have other data also. Again, I'm just trying to support my theory here, but when this was a study that recently was published looking at PET scanning and using that as using that to measure coronary flow reserve. And when they found that you had abnormal coronary flow reserve, particularly those under 1.6, they found that women suddenly had more adverse events compared to men. And part of the reason for that was really the fact that what we saw with men were obviously, with the abnormal coronary flow reserve, were more likely to have 1 or 2 vessel disease. The problem was that women were less likely to have an obstructive lesion. And they weren't necessarily treated with guideline recommended therapy, and then they did go on to have worse outcomes, at least in this smaller study. But it was a good study in the sense of what the use of PET might be in terms of detecting ischemia in women, and maybe being able to use that also as a tool, because we really don't know what the gold standard should be to be able to detect microvascular disease or endothelial dysfunction. What we do have, though, and what we have created is a model for ischemic heart disease in women, which is different than that model that I think most of us learned from, is that when you have a normal coronary artery, obviously that will not bring any attention to someone, but all the other risk factors, some sex-specific, some that are not sex-specific, ultimately can impact the coronary vessel before there's any obstructive lesion, and that maybe that's the earliest stage, is microvascular dysfunction, and then they go on to have subclinical atherosclerosis or an obstructive lesion, but that would be later on their stage, and that we would actually believe that symptoms can start manifesting them actually at the after all these risk factors have affected the vascular system in an abnormal way. And it may be true that it's not even just sex specific. There may be men that also have this. We know that some of the Italian data has actually looked at both men and women who had myocardial infarction but had no obstructive lesions. The other thing that may surprise you, though, in terms of the fact that we haven't studied women all that great, when we think about the way research goes, we think that there's cell studies done, animal studies done, and then human studies done. And if you look at cardiovascular disease, the fact is, and this may be true for other diseases, but we did not actually use female sex cells. We did not use female animals. So all our preclinical studies before it got to humans did not include the female sex at all. And you probably saw this paper that Janine Clayton and Francis Collins wrote from the NIH that was published in Nature. And they said that now, okay, we need to be actually including both sexes when we do cell studies and animal studies. That was only in 2014. And it was only in 2016 that if you have NIH funding that you actually have to report this and have equal representation. I don't know if male mice were cheaper. I don't know if women mice don't like being in cages, but I don't know why women or female sex lines were not used. And this, I think, we should all be concerned about. And I'm happy that this has changed, but we have not yet seen the data yet that will translate into a meaningful way yet to our clinical studies. What I will say, the good thing of using female mice is they have that pesky problem also of getting pregnant. And that really is important because for our female population, we really need to know how changes in hormones are going to affect. And that used to be a reason not to include women in trials, but we really need to know their role. So, and I think nobody would argue that, sex, what we're biologically determined, affects our risk, as does gender, as does all the other risk factors that we do look at. But if we don't study the basic physiologic genetics that we're given, we're not going to be able to make as good of a headway as we want to on really understanding cardiovascular disease when it affects both men and women. And I'm not really for studying women alone. I'm actually really for studying sex differences because I really think that's how we're going to learn if there are differences. I wrote this editorial just a few months ago that, there's a lot of other heart disease I could talk about. I mean, I know you have many of the experts in this room, so I'm not going to go in them in too much detail, but heart failure with reduced ejection fraction, we know women are less likely to receive life-saving medications, they're less likely to get ICDs implanted, they're less likely to be offered VADs, and they're less likely to undergo heart transplantation. Heart failure with preserved ejection fraction, this is a disease much more common in women, and there's really no good guidelines for diagnosing or treating this at its earliest stages. We don't know exactly how to treat it and impact outcomes, and this is something that does affect women. And certainly PAD, another disease, it's twice as common actually in women compared with men. They have women who suffer from PAD, they have greater functional impairment, and yet they're less likely to undergo revascularization for that. And if they do, it's often emergent. So these are many of the other areas, that sex matters and that we really need to take a more critical look. But the things that we can be doing, and this was one of my statements, was that the persistent pattern of poor cardiovascular outcomes appears predominantly attributable to suboptimal use or even lack thereof of guideline recommended therapy in women. Despite the strong evidence that management of cardiovascular disease with evidence-based therapies benefits both sexes equally. So that's at least a starting point of where we can start. The guidelines that we have that apply to both men and women, at least we should be applying that while we wait for other things. But I will say that, women are not small men, and that's a reason that we need to study them. The other thing I want to just briefly touch on is specifically risk factors, if you will, because I think what we should be doing is more of preventing heart disease. And there's many risk factors, obviously, that affect both men and women, but there is some sex-specific risk factors. And it's certainly important to know the risk factors that affect both men and women. They might affect them differently, like diabetes, increases the risk of cardiovascular disease much greater in women than in men. Smoking as well affects women more adversely than men. But there is sex-specific ones, like gestational diabetes, polycystic ovarian syndrome, preeclampsia, any type of gestational hypertension. Lupus and rheumatoid arthritis are female predominant conditions, so they're important that we recognize them and be assessing them for risk. But, we have this risk calculator through the ACC and the American Heart Association, and we are able to calculate risk. And I know it's confused many people, but it really has been validated internally and externally. But what I will say is that I think that there's some things, aside from just plugging in the sex of a patient, I think there is missing in here sex-specific risk factors. And I think this is the starting point, but not the ending point for our patients. So what do I think is missing when we assess ASCVD risk in women? Well, we have lots of data now about preterm delivery and cardiovascular disease. And by preterm delivery, we've used that as delivering preterm before 37 weeks of gestation. And we have data, as you can see here, this was a 10-year follow-up, and you can see that those who had preterm delivery compared to those who had normal term delivery were more likely to have cardiovascular events in the next 10 years. You think about the age of people who are having children in the next 10 years having cardiovascular events makes these young women. We had more recent data that just came out this year, and they teased it out a little bit better, I think, because they said certainly preterm delivery, 32 weeks to 37 weeks, didn't seem to be statistically significant, but maybe those who had children before 32 weeks of gestation, they were the highest risk group, and those were the ones that were at the highest cardiovascular risk in this particular study. But that that even after you controlled for traditional risk factors. And maybe that's what we should be asking. At the very least, we should be asking if they've had preterm delivery and try to at least get those records, or have gynecologists recognize that they're at higher risk and be sending those patients to us. Gestational diabetes as well. We have a lot of data, and I just like these population studies. This was from France, from all births in 2007 to 2008, and followed for 7 years. This was just last year. That was 1.5 million deliveries in France, and 62,000 of them had gestational diabetes. And they found that they had a higher risk of angina, MI, and stroke over time. And again, you think 7-year follow-up. These are young women going on to have cardiovascular events, not the ones that we traditionally think about having heart disease. And again, population studies, I think, are incredibly powerful of showing what will happen to them. Same with hypertension during pregnancy. And that can be any form of hypertension, not just preeclampsia, any form of hypertension. And many studies, and these are just some of them, that have shown a relationship with high blood pressure during pregnancy, not just predicting future hypertension, but predicting future cardiovascular disease. And again, a really nice, elegant population study came out of northern Finland. This was, again, a study from they followed all these women who gave birth in 1966 and have followed them ever since. And they found that elevated blood pressure during pregnancy, and they teased out all the different types of hypertension compared to the normotensive, which is the black line. So whether it was isolated systolic, diastolic, whether it was preeclampsia, whether they already had hypertension before pregnancy. So all of these things, what was interesting, they again said they had a higher risk of future hypertension, higher risk of cardiovascular disease, but also a higher risk of diabetes and chronic kidney disease. And that, I think, is really, again, all risk factors that we care about. But these are, again, a group that often, after the hypertension goes away postpartum, we never see them, and often their gynecologists don't educate them necessarily that they need to be worried or that they're at higher risk for cardiovascular disease. So some of this data has really motivated both cardiologists who take care of women and the OB/GYN groups to get together, and we're actually working now on a document to try to what should we be doing for these women, because we should be thinking of pregnancy really as a crash test or a free stress test, if you will. I mean, really, when women are pregnant, we're actually getting some sort of vascular response that is telling us that they're at a higher risk of heart disease, and we should actually be asking that as part of our cardiovascular risk assessment. Other things that aren't necessarily unique to women but happen more frequently in women is breast cancer. And now breast cancer, we have a 95% plus survival rate because our medications have gotten so good, our therapy is so good. And yet, what they're at higher risk of dying from is actually cardiovascular disease. And so that's another group we need to really work with. And it's partially the disease because the risk factors overlap, but it's also partially the treatment. Breast radiation, we know chest radiation increases the risk of cardiovascular disease. We also know in the United States that if you have left-sided breast cancer, for whatever reason, we tend to give more radiation to the left breast than the right. And we don't have a good reason for why, just the tumor size and different things. But we know there's an association with more radiation and cardiovascular disease. Anthracyclines, which is a mainstay of the therapy for breast cancer, also increases the risk of heart failure. If you get Herceptin, it can increase the risk of heart failure, but it can also increase the risk for cardiovascular disease. And if you get all of the above, it increases your risk even more so. And again, these are not traditionally things we ask. At least we should ask if you have a history of breast cancer, but we should also try to tease out the therapy so that we know what we might be expecting. And certainly the idea of radiation, I mean, we usually don't know how much radiation they got. It's very hard, in my experience, to tease that out or get that from any particular record. But we know for every grade that they get additionally, they increase the risk for cardiovascular disease by 7.4%. And again, the average radiation to the right breast is 1 to 2 grays, and it's usually higher in the left breast for some reason, and we don't know the answer for why, but we shouldn't minimize that. And if they start out with more cardiovascular risk factors, they actually have a higher risk. So that of course makes sense, but these are things that we should be asking. So my personal approach of taking care of women in terms of risk assessment is certainly I still use the ASCVD risk score. And if I'm lucky enough to have coronary calcium testing at the time, I'll use the MESA risk score, which has also been well validated and actually incorporates the coronary calcium score to be part of risk assessment, since I think that's really coming to be a very good risk tool. Then I'll ask about sex-specific risk factors, like the adverse pregnancy outcomes that I touched on. Ask about breast cancer or any type of chest radiation. Ask about hormone replacement therapy in menopausal state. Then I'll ask about these female predominant conditions like lupus and rheumatoid arthritis. And then obviously that's how you personalize it. We can talk about precision medicine if we don't really even care about the sex of the patient or the sex-specific risk factors. That's to me is precision medicine. The genetics and all the rest of it is important, but I think that this is where you start. It's cheap and easy and a way to really get to know our patient's risk. And then I will end with saying something that I think most of you in this room already know, but this is from 2016, because I can't tell you anything about politics in 2017. But this is what was given to us in 2016. The NHLBI was given $3 billion. The NCI was given $5 billion, even though the number one killer is cardiovascular disease for both men and women. And in terms of women's specific research for heart disease, what we can best tease out was about $409 million was given from the NHLBI. In breast cancer, received $705 million last year. The Department of Defense also gives research dollars, and they gave $150 million to breast cancer, but heart disease for women specifically was one of their 39 programs that they might divide $279 million to, and I'll tell you in 2016 they didn't give any money to cardiovascular disease in women, but they have the option to. And despite that, we know that, the NHLBI reports, and when you look at the report, they said now nearly half of their studies, 46% of their funded trials are women. And yet I don't see those trials, but that's what the NHLBI does say. We know that from the Women's Health Initiative, that for every dollar that was given to the Women's Health Initiative, $140 was net returned to society. So there is a reason to study women, and I guess us, we as a cardiology community just need to be fighting for more money to do more good, to reduce the deaths, because the deaths are disproportionate to any other type of disease. So we're really at the infancy, though. Let me just show you quickly a timeline. The pink ribbon was introduced in 1991 and quickly was adopted by the next year. Everyone knew what the pink ribbon stood for, and I think everyone sees anything pink and your automatic assumption is it's related to breast cancer. But for heart disease, we haven't really been able to always get our red dress to be universally recognized. And Women's Health Initiative started in 1993. The WISE study that I talked about started in 1996. The Heart Truth campaign actually started by the NHLBI in 2001, and then the red dress symbol was adopted shortly thereafter. But the American Heart Association took over the red dress campaign in 2004 and then released guidelines that same year. And then in 2007 and 11 also we released guidelines, and there's been no guidelines since that time for a lot of different reasons, but none of which I think are really great. We actually did have stroke prevention guidelines come out in 2014, but I will tell you that I think that we're at the infancy of really understanding women and their hearts, and I do think that it is time to reconsider if the red dress is the right symbol or if a red heart would be enough, if there's a way to make women understand their risk better. All these are questions I think that we should reconsider, but again, just remembering that we've only really just begun. And I will say, I'll just stop now. I'll just give you my conclusions, is that I hope I've convinced you that there is sex differences in cardiovascular disease. I think that at this time there's a lot of things we don't know, but the things that we do know and the guidelines that we have, we should be using our guidelines in women, because we know women are less likely to receive guideline-indicated therapy, and there's really no good reason for that. Our youngest women are at the greatest risk for poorer outcomes, and that's a group that we continue to study and try to determine why we're treating them differently, but also why they're doing so poorly. The other area is this whole idea of non-obstructive coronary disease, also known as ANOCA or MINOCA, depending on what they've had, that we need to figure out more what's going on with that, because we don't yet know what the actual ideal therapy for that is, and we have a lot more work to go there. And I will just say that women are more complicated, so we're going to have to spend more time. So, and that's it. So thank you for your time.
Thank you, Martha, for an amazing presentation, opening our eyes to various statistics that I personally, some of the statistics, particularly for women, are quite impressive. And I will start with that, is why, with a tenfold higher incidence, right, of breast cancer death compared to cardiovascular death in women, right? And exactly, and women, cardiovascular. There is, I think, in the public and even in the physician and the healthcare professional, less awareness of that.
Yes.
Well, what should we do?
Yeah, I mean, that is really the problem, is that, the awareness remains that from patients, we've really educated women really well. They know to go for their mammogram. It was covered with the Affordable Care Act. You didn't even need a doctor's prescription to get that done. And yet there really was very little said in the Affordable Care Act about cardiovascular disease prevention. And I think that was, who knows where healthcare is going to go, but we really need to make that the primary focus for women and men, to be honest, that if we want to prevent disease and reduce cost to our healthcare system, ultimately it's going to come from CVD prevention. Breast cancer, it's not to belittle it. I mean, obviously, we are happy that women understand it, go for their screening, do what's right. But we need to revamp our public education campaign. I think that that's what we really need to reconsider.
Question.
Dr. Gulati, thank you very much. I think that's a very important topic and enlightening, especially the numbers speak for it, but we don't think about it on a daily basis. I have a comment and a question. I'm glad you showed the slides about mice, men and women mice, or we've had a heart failure mouse model for years together, which was mostly male mice, I have to confess. But interestingly, our colleagues in Metabolic Institute started working on impacts of hormones and oophorectomy and used female mice. And the same protocol causes a completely different phenotype in the female mice controls in their experiments compared to our experiments. The male mice drop their heart failure, EF drops their EF early on. The female mice don't drop their EF at all. And I think, as you suggested, there is much more to the pathobiology, the difference between the X and the Y chromosomes when you look at the genetics. My question to you is, have you learned about the genetic differences from the GVAS studies that have come up in the last 5 to 6 years in cardiovascular disease, that we can start getting to the molecular level of understanding the differences either for heart failure or for coronary disease?
Was there a question?
The question
I'm
was,
sorry, I agree with you on
do
all
we-
those points, but
do we
I'm having
have-
a little trouble hearing you, I'm sorry.
do we have an insight from the recent GVAS study, the Genome-Wide Association studies that came up with the chromosome 9? Have there been studies understanding the difference between men and women at the genomic level from those big studies that we've had?
Yeah, I don't, this has been the problem, is that we don't have a lot of data, but the genetic studies, I think, are probably also another issue that this is the problem, again, that I will say that we need to study men and women, because a lot of our studies, if we just study women, we don't have a sex comparison. So even with Ys and with my Women Take Heart, we do have genetics on that. But again, it's all female, so we don't have a sex difference. But I do think going forward, that's what we should be doing, is really making sure that we try to compare and contrast.
Other questions?
Question over here. Thank you for that fantastic talk, and I certainly appreciate the efforts to influence the NHLBI, but as you mentioned, how many studies are we really seeing that show that impact? And I think about the trials that we are part of in terms of industry-sponsored trials, randomized, whether it's TAVR or LVAD or newest medical therapy. I don't see any influence, or I don't feel it in terms of ensuring we're screening an appropriate percentage of patients that are women to understand sex differences, perhaps on the back end. So my question is what has been your approach with industry, or is there a movement to influence industry? Because I think working with the FDA is largely on the back end many times. And so how has that been, and is that a prioritized consideration to move the needle, if you will?
Well, I think that our approach should be, because many people in this room are key opinion leaders, people ask you what should be done, is that these are the questions I ask them. I'm like, where are the women? Are you going to follow it long enough? So recently I was asked about the PCSK9. I said, don't make the mistake that statins did, because they didn't, when they closed their study, they didn't continue. Women never met the endpoint. And that's always been the criticism for primary prevention in women related to statins is there any data that it saves lives in women? And when you really tease out the data, it really wasn't statistically significant. You can say all you want that it trended towards, but if it's not statistically significant, you'll still have the Rita Redbergs of the world telling us that there's no proof that these drugs are effective, and I agree with her on that point. I think that for any studies in any field that we're involved in, we should be pushing industry to, one, include women and make that a priority, but make sure, depending on what the disease is, are we following them long enough? Are we, should they power the studies for women, for secondary endpoints that are specific to what we need for women? I think that will make a difference, because when industry at least meets their endpoint, they close the study, because ultimately they want their drug, their device out on the market, and that's really where it ends for them.
Thank you for a very nuanced talk about the difference between us and you guys. More than smoking in young girls to maintain weight so that they can look like Hollywood. Don't you think that part of this is really cultural? Most women get their medical care from gynecologists. And gynecologists look at bones, and until recently, Pap smears, and that's gone by the by. and they look now at mammograms. Should we ask the American Board of Obstetrics and Gynecology to have the guys and the girls who eventually segregate themselves into gynecology, they have a year of general medicine as part of their training, and then go into gynecology, which, as we all know, is really apart and aside from medicine. It's a different world.
I actually totally agree with you. I will tell you that we know when we've done surveys of women and we ask who is their primary care physician, they say that their gynecologist is their doctor, more likely than an internist or a family physician. So that is the truth. We are actually working, so I will say the American College of Cardiology, we have a women and cardiovascular disease section, which I sit on, and we actually have a representative from ACOG on the group. And we have actually been, the American College of Obstetrics and Gynecology, sorry, and we also have been doing a lot of work with them in terms of education, not just for the future generation, and I agree, I think that's a great idea for their training program to get more, even to do some rotations and on more than just cardiovascular disease, the other diseases because they end up being the person that everyone's turning to. But we are working on educating the current physicians that are out there practicing, making educational for them. They've been really great partners, actually, and interested in getting more information because as they're seeing, especially this adverse pregnancy outcome data, they're also trying to figure out what should we do. And so we actually are just starting where I am, where I'm actually having a clinic with the gynecologists they see that any hypertensive patient at least 6 weeks postpartum, and we want to be outside the door so that they can see us as well on that same visit, at least to do an initial cardiovascular risk assessment and maybe engage them to come back in a year. I think that we have to partner with them, though, from a cardiology standpoint, because they are the front line. They are the primary care that we're all talking about. We can't just target primary care like internal medicine physicians, so that's a great point.
Well, with that, I want to really thank you for an amazing presentation. That was great.